Hello everyone. In brief, today I am going to tell you about the nebulization therapy in children. So learning objectives, what is the basic principle, what are the equipments, what are the drugs we can give by this route and how to give. So to deliver the drug by the inhalation route, we use the nebulization, and nebulizers are basically capable of converting the liquid medicine into the aerosol droplets, which is suitable for the inhalation. So what are the types of nebulizer? There are three main types: jet nebulizer, mesh nebulizer and ultrasonic nebulizer. At most of the places, jet nebulizer is used. Here also we are using the jet nebulizer. The mechanism behind the jet nebulizer: compressed air in the jet nebulizer convert the liquid medicine into the aerosol droplets or mist, and these tiny particles of the medicine float in the air, and by inhalation route it is go into the respiratory tract. In mesh nebulizer, liquid medicine is passed through the tiny mesh. Then it creates the fine aerosol particles or mist. In ultrasonic, high frequency vibration turns the medicine into the aerosol droplets, and the size of the droplets tends to be bit larger in the ultrasonic nebulizer compared to the jet and mesh, and it is also little bit costlier compared to the jet and mesh nebulizer. We can give the various drug by the nebulization. So adrenaline and budesonide both use in the whenever child is coming with the acute laryngotracheal bronchitis group. These bronchodilators, salbutamol, ipratropium, bromide and terbutaline, use in the asthma. Hypertonic saline 3% NS we use in the acute bronchiolitis. There are various other indications also. Details I will tell you in next few slides. N-acetylcysteine and human recombinant DNAse is mucolytic and used in cystic fibrosis and various other condition in which thick secretion block the airway. We can use both the drugs. Ribavirin by the inhalation route used against the respiratory syncytial virus. It is antiviral drug. So in acute bronchiolitis we use this drug. Antibiotic by inhalation route mainly used in the cystic fibrosis. So what is the indication of nebulized adrenaline? It is indicated whenever patient is having moderate to severe croup to relieve the obstruction which is because of upper airway swelling. Whenever patient is coming with the severe bronchiolitis, again to relieve the obstruction we use the adrenaline. And in anaphylaxis, whenever patient is coming with bronchospasm due to anaphylactic reaction, to relieve the airway obstruction, airway swelling, we use the nebulized adrenaline. And after extubation, in post extubation, we use the nebulized adrenaline whenever patient is on mechanical ventilation, and after doing the extubation trial we use this drug. So the concentration of adrenaline in ampule is 1 milligram in 1 ml, 1 is to 1000. So it is available in the injection form. What is the dose of nebulized adrenaline? Either we can give directly 0.5 ml of 1 is to 1000 solution in 3 ml normal saline in emergency, or we can give 0.1 to 0.5 ml per kg of 1 is to 10,000 dilution. So to make this 1 is to 10,000 dilution, just you have to take the 1 ml adrenaline and then you have to add the 9 ml normal saline in this. Then it will become the 1 is to 10,000 dilution, and directly you have to choose a 0.1 to 0.5 ml per kg. Example, 10 kilogram baby is there with the acute bronchiolitis or acute laryngotracheal bronchitis. We can choose a dose between 0.1 to 0.5, depends on the severity. So for 10 kg baby 1 ml, 0.1 into 10. So 1 ml of 1 is to 10,000 dilution we can use, and maximum we can take the 5 ml of 1 is to 10,000 dilution for the nebulization. And frequency we have to keep every 4 to 6 hourly. Adrenaline is a sympathomimetic catecholamine. Its action on alpha and beta adrenergic receptor. So it induces the relaxation of the bronchial smooth muscle by acting on beta adrenergic receptor and alleviate the wheezing and reduce the airway edema. Action start as early as 30 minutes after giving the nebulization and lasts for 2 to 3 hours. So rebound can occur after 2 to 3 hours. So we can repeat every 2 to 4 hourly whenever patient is having severe acute bronchiolitis or severe croup. What are the side effects? It causes tachycardia, palpitation, tremors, and also hypertension, create the anxiety. Sometimes arrhythmia can also be there. Now the second drug is nebulized budesonide. It is indicated in croup. As we know, budesonide is having the strong anti-inflammatory effect. So whenever patient is having the croup, laryngotracheal bronchitis, there is an inflammation of larynx, trachea or bronchial tree. So it is very effective with adrenaline nebulization. So we have to start nebulized budesonide and nebulized adrenaline whenever patient is coming with the acute LTB to decrease the inflammation and to decrease the obstruction, and it also decrease the secretions in the airway. It is also effective in asthma, but preferably as a maintenance treatment or prophylactic therapy for the patient with the asthma. Whenever patient is coming with the acute asthma attack, we prefer the systemic corticosteroids, either prednisolone or methylprednisolone. So when patient is shifted on the maintenance treatment, we prefer the inhaled budesonide either in the nebulization form or by the inhaler. It is also effective in preventing the bronchopulmonary dysplasia in preterm baby, those who are in NICU and on long oxygen therapy on mechanical ventilation. There are chances of developing the BPD. So it is effective in prevention and also role as a therapeutic whenever patient is developing the BPD. Also effective in COPD and also effective in early stage of sarcoidosis. So these are the indications of the nebulized budesonide. Budesonide in the nebulization form available, example in Budecort respules 0.5 and 1 milligram in 2 ml solution. So this is the concentration available in Budecort respules. Dose of the nebulized budesonide in croup. We label the mild croup whenever patient is not having stridor at rest and able to take the feeds, conscious and oriented. In this, we have to give the single dose of nebulized budesonide 1 to 2 milligram in 2.5 ml normal saline. And again, we have to reassess after 12 hours. If still the patient is having the symptoms, then we can repeat the nebulized budesonide. Otherwise, single dose is sufficient. In moderate and severe croup, when the patient is having the stridor even during the rest time, also not able to take the feeds, patient is having either irritability, restless and not having the normal conscious level, then we have to start the nebulized budesonide 1 to 2 milligram in 2.5 ml normal saline every 12 hourly. We should continue for 2 to 3 days with nebulized adrenaline. First dose of adrenaline is 1 ml in 3 ml normal saline, 1 is to 1000. Then second dose and onwards, we have to give the similar dose as I explained in the previous slide, 0.1 to 0.5 ml per kg of 1 is to 10,000 dilution. Maximum we can give up to 5 ml. And we have to repeat every 6 to 12 hourly. And this should also be continued for 2 to 3 days. What is the dose of nebulized budesonide in asthma? We have to give the 1 milligram in 2.5 ml normal saline over a period of 20 minutes, and this should be followed by 0.25 to 0.5 milligram twice a day nebulization in less than 12 years old baby, and 1 milligram budesonide twice a day in more than 12 years baby. Budesonide has the most rapid onset of action among the all inhaled corticosteroids, and significant improvement usually observed 1 to 2 hours after giving the treatment with the inhaled budesonide. What is the mechanism of action of inhaled budesonide? As I said, it is having the strong anti-inflammatory effect. It reduces the airway hyperresponsiveness and reducing the bronchospasm also. It decreases the mucus production and suppresses the immune cell activation. So very effective in croup, asthma. What are the adverse effects of the nebulized budesonide? Mild throat irritation can be there. Patient may have the pyrexia, sinusitis can develop, and oral thrush, fungal infection of the oral cavity and even the pharynx can develop after nebulized budesonide. So always we have to counsel the parents that child should rinse the mouth with water and spit all the deposited drug out immediately after giving the nebulization. It will prevent the systemic absorption also, and also prevent the fungal infection of the oral cavity and pharynx. Candidiasis can be prevented. Hoarseness of voice and sometimes bronchospasm can occur, and patient may have the headache with nebulized budesonide. So these are the adverse effects of inhaled budesonide. Now the third drug is salbutamol. It is effective in acute asthma to relieve the bronchospasm in children, those who are having the severe exacerbation of the asthma and having the breathlessness, wheezing, airway obstruction during the acute asthma attack. It relieves the bronchospasm in other conditions also other than asthma, example exercise induced bronchospasm or in COPD. It's little bit role in bronchiolitis or doubtful role in bronchiolitis. If patient is improving, then we can continue. If patient is not improving, then we should stop the nebulized salbutamol in bronchiolitis. And salbutamol is contraindicated whenever patient is having laryngomalacia and tracheomalacia. So what is the available concentration of salbutamol in ethylene solution? It is 5 milligram per ml concentration. Now what is the concentration in ethylene respules? It is 2.5 milligram salbutamol in 2.5 ml, means 1 milligram in 1 ml, while in the solution it is 5 milligram in 1 ml. Nebulized salbutamol in combination with the budesonide available in Budesal respule. So concentration 1.25 milligram levosalbutamol and 0.5 milligram budesonide in 2 ml respule available. Dose of the nebulized salbutamol in acute asthma exacerbation is 0.1 to 0.15 milligram per kilogram per dose, minimum 1 milligram dose, and should be diluted in 3 ml normal saline given over a period of 15 minutes. And we have to repeat similar dose 3 doses in 1 hour using the airflow 6 liter per minute. And then after this 1 hour 3 doses of nebulized salbutamol, we have to repeat the similar dose every 4 to 6 hours interval. Instead of this intermittent nebulization, we can give the continuous nebulization in very severe exacerbation of asthma. Dose is 0.15 to 0.5 milligram per kilogram per hour. Or according to body weight also, we can remember if weight of the child between 5 to 10 kg, then 5 to 7.5 milligram in 1 hour. If between 10 to 20 kg, then 10 to 12.5 milligram in 1 hour. If more than 20 kg, then 15 to 20 milligram in 1 hour. So this is for the acute severe asthma exacerbation. What is the mechanism of action of the salbutamol? It is short-acting beta-2 agonist SABA. So it relaxes the bronchial smooth muscle. It is a bronchodilator, very effective drug in asthma. What are the side effects? Patient can develop the tremors, headache, tachycardia, palpitation, irritation of the mouth and throat, muscle spasm, and hypokalemia, especially when the patient is severe acute malnourished and also having the asthma. Then this side effect we should keep in mind. And GER can also develop with the inhaled salbutamol. Nebulized ipratropium bromide is very effective in asthma. This should be used as an adjunct to the salbutamol in acute severe asthma exacerbation. It can be mixed with the salbutamol in same nebulizer, and we should keep in mind this should not be used as a first line drug in asthma. This should be used as an adjunct to the salbutamol whenever patient is not responding with only nebulized salbutamol, we can add this drug. It is very effective. Ipravent Respule contain the 500 microgram ipratropium bromide in 2 ml Respule. Duolin is a combination of ipratropium bromide and levosalbutamol. Levosalbutamol 1.25 mg with ipratropium bromide 500 microgram in 2.5 ml solution in Duolin Respule. What is the dose of ipratropium bromide? 125 to 500 microgram every 20 minutes for 3 doses in 1 hour with salbutamol. Using the airflow 6 liter per minute can be given in acute severe asthma exacerbation. And after these 3 doses in 1 hour, we can give at 4 to 6 hours interval with the salbutamol. And whenever weight of the baby is less than 20 kg, we can give the 250 microgram ipratropium bromide, and more than 20 kg 500 microgram ipratropium bromide. Now the mechanism of action of the ipratropium bromide, it is anticholinergic bronchodilator. It inhibits the acetylcholine induced bronchospasm. It is short acting muscarinic antagonist. Act on the muscarinic receptor mainly on the larger airway rather than small airway. Has the weaker bronchodilation effect, slower onset of action and longer duration of effect as compared to the SABA, salbutamol. What are the adverse effects? Causes a headache, dizziness, sweating, anxiety, tachycardia, palpitation. Sometimes skeletal muscle fine tremor, muscle weakness, myalgia, muscle cramps. Potential severe hypokalemia due to the ipratropium bromide. Nausea, vomiting can also be there. Now the next drug is nebulized terbutaline. It is also effective in acute asthma. Also used in combination with the salbutamol for rapid relief of bronchospasm. What is the concentration of terbutaline in bicanal nebulization solution? Concentration is 2.5 mg per 1 ml in 2 ml respiles. What is the dose of terbutaline in acute asthma attack? 2.5 to 5 mg can be given every 20 minutes, or we can give the 5 to 10 milligram in 1 hour, or as a continuous nebulization also 0.1 to zero point 0.3 milligram per kilogram per hour in 1 hour. This should be followed by 2.5 milligram for children less than 20 kg body weight and 5 milligram for children more than 20 kg body weight. We can repeat every 8 to 12 hour interval in acute severe asthma. What are the side effects? Headache, palpitation, tachycardia, tremors, muscle spasm can be there. Now the next drug is hypertonic saline, 3% normal saline. It is indicated in acute bronchiolitis, bronchiectasis and cystic fibrosis. It is very effective in acute bronchiolitis. So after the oxygen therapy, inhaled nebulized hypertonic saline and nebulized adrenaline both should be started in acute bronchiolitis. What is the mechanism of action of the hypertonic saline? It improves the clearance of the mucus because it acts as an expectorant. Osmotic pressure of the 3% NS is more than physiological isotonic 0.9% NaCl. And because of hyperosmolar agent, it draw the water into the airway, rehydrate the mucus layer and improve the mucociliary clearance. So helpful for clearing the mucus secretions. It also decreases the mucus plugging because it breaks the bonds within the mucus gel. So reduce the cross-linking and lower the viscosity and elasticity of the mucus secretion. So decrease the plugging of mucus and also reduce the airway edema because of its osmotic effect. Hypernebrespule contain the 4 ml of 3% sodium chloride. What is the dose of hypertonic saline? 3 to 5 ml every 6 to 8 hourly with the oxygen flow rate of 6 liters per minute we have to give by the nebulization. Most of the time there is no side effect due to nebulized hypertonic saline, but sometimes patient can have the worsening cough and anxiety which can be spontaneously resolved. Bradycardia, bronchospasm, desaturation can also occur very rarely, so we have to stop the nebulization immediately. Nausea, vomiting can occur. Another drug is nebulized N-acetylcysteine, which is indicated in bronchiectasis, cystic fibrosis, and COPD. It is mucolytic. What is the mechanism of action? It is a classical mucolytic agent. Unique hydrosulfuryl group breaks the disulfide bonds between the mucin molecular complex. It reduces the viscosity of sputum, making the mucus clearance easy. It promotes the ciliary movement, improve the mucociliary clearance capacity. It also has the antioxidant effect. It is mediated by the increased level of intracellular reduced glutathione in the lung and neutralizing oxidants. Solution Mucomist 20 solution of 20% contain the 200 mg per ml N-acetylcysteine and also 10% Mucomist solution available which contain the 100 mg per ml N-acetylcysteine. What is the dose? 4 ml of 20% solution or 8 ml of 10% solution can be used in the nebulizer 3 to 4 times in a day whenever patient is having cystic fibrosis and in other indications. What are the side effects? Irritation to the nasopharynx GIT, nasal discharge, stomatitis, nausea, vomiting can occur. Another drug is nebulized ribavirin. It is indicated in severe respiratory syncytial virus infection in children and severe acute respiratory syndrome SARS due to the coronavirus also has some improvement with the nebulized ribavirin. Influenza severe cases and in immunocompromised children, so its effect against the influenza virus also in the literature. Ribavirin is a nucleoside analog and an inosine monophosphate dehydrogenase inhibitor. Inhibit the viral RNA synthesis, interfere with the viral replication. 100 ml glass vial of the ribavirin contain the 6 gram of drug and this should be reconstituted with the 300 ml of sterile water. Then the solution will become which contain 20 milligram ribavirin per ml. And the dose of ribavirin is 20 mg per ml solution with the continuous aerosol administration for 12 to 18 hours per day for 3 to 7 days in acute bronchiolitis. What are the adverse effects of ribavirin? Sometimes patient may develop the respiratory side effect, wheezing, coughing, bronchospasm. In cardiovascular side effect, hypotension can develop. Nausea, vomiting can develop. Patient may have the anemia, neutropenia due to this drug. Sometimes headache, fatigue, and sometimes hypocalcemia, hypomagnesemia can also be there. Another drug is aerosolized antibiotics, which is indicated whenever airway are infected with Pseudomonas aeruginosa, especially in cystic fibrosis. So we can give the antibiotics tobramycin, aztreonam, amikacin, levofloxacin. Inhaled tobramycin is very effective, and other drug also effective against the Pseudomonas by the inhalation route. Last is aerosolized human recombinant DNAse indicated in bronchiectasis and cystic fibrosis. Its mechanism of action is it dissolves the extracellular DNA released by neutrophil, which is main contributor to characteristically sticky and viscous airway secretion. It improves the pulmonary function, decrease the number of pulmonary exacerbation by this action. DNase alpha available for the human recombinant DNAse. It contains the 2.5 mg per 2.5 ml. What is the dose? 2.5 mg given as a single daily aerosol dose. Drug should not be combined or mixed with the other solution. What are the side effects? Common side effects: voice alteration, pharyngitis, rhinitis, rash, chest pain can occur. Less common side effects: laryngitis, hoarseness, sore throat, cough, conjunctivitis, dyspepsia, urticaria, headache can occur. Antibody development against the DNase alpha seen in 4% of the patients. Thank you so much. This is all about the nebulization therapy. In next part, I will tell you how to give the nebulization. Thank you so much.